Hello, Group 8 here, and today we're going to tackle about sexual dysfunction. So first, what is sexual dysfunction? First, um, it is a problem that can happen during any phase of sexual response cycle. It prevents you from experiencing satisfaction from sexual activity. Sexual response cycle traditionally includes excitement, plateau, orgasm, resolution. Desire and arousal are both part of excitement phase of sexual response. It is important to know that women don't always go through these phases in order. While research suggests that sexual dysfunction is common, many people don't like talking about it because treatment options are available, though you should share your concerns with your partner and healthcare provider. So we have here the different types of sexual dysfunction. First, we have desire disorder, which means lack of sexual desire or interest. Ibig sabihin, wala sa mood si partner magkaroon ng sexual activity with you. Next would be arousal disorder. Inability to become physically aroused or excited during sexual activity. It means na although may desire si partner magkaroon ng sexual intercourse, hindi po siya makaramdam ng arousement. Like, walang feeling. Dead ang ating pakiramdam when it comes to sexual activity. Next would be orgasm disorder. The delay or absence of orgasm, or sabihin na po natin yung climax. Though nape-penetrate ang private part ng ating sexual partner, but at the same time, nagkakaroon siya ng problem magkaroon ng climax. And dito na magpo-fall kung bakit nagkakaroon ng dissatisfaction ng isang partner or couple with another one kasi hindi siya naka-reach ng climax through the sexual activity. Next one would be pain disorder, which is, from the word itself, pain during intercourse. Siyempre, kapag masakit, hindi gugustuhin ni sexual partner na magkaroon ulit ng another intercourse kung nahirapan siyang makag-lick. So, under sexual dysfunction, we may also tackle about the delayed ejaculation, which is defined by condition where it takes a long time or a lot of stimulation for a man to ejaculate, or he may not ejaculate at all. This causes distress or interpersonal difficulty among men. So, minsan may napapansin tayo, either, syempre malalaka naman tayo, si partner, nagkakaroon siya ng low self-esteem when it comes to having delayed ejaculation. In this type, dito na din magpo-fall yung lack of sexual desire kasi wala silang confident to do that. Baka mabuli sila or hindi nila masatisfy yung female partner nila. Kaya nagkakaroon tayo ng delayed ejaculation. It would be also genetic reason. For diagnostic criteria nito, ayon sa DSM-5, which requires persistent or recurrent or lack of sexual desire, as I mentioned earlier. Siyempre, normal lang naman na hindi magkaroon ng sexual desire si partner from time to time, but this diagnostic criteria would be requiring a persistent or recurrence of lack of sexual desire, which means nakikita mo na talaga na ayaw na ni male partner magkaroon ng sexual interaction dahil sa delayed ejaculation niya. Medyo nahihiya, natatakot. So, yung diagnostic features nito would be considered as distress and exclusion of other factors. It also distinguishes between lifelong versus acquired, would be generalized versus situational types of delayed ejaculation. Lifelong would be, syempre, pang matagalan na since sira na yung confidence ni male partner. Yung acquired siguro, nagpo-fall pa dun yung nabubuli siya or nasabihan siya ng previous sexual partner niya na hindi sila na-satisfy with their performances. Generalized reason would be ayun nga, lahat ng rason kung bakit nagkakaroon siya ng delayed ejaculation, kasama na din psychological and physical. Situational types, nagkakaroon siya ng delay sa ejaculation just because of some reasons. Pero hindi naman literal na lahat na some reasons. So, paano ba nagde-develop yung gantong sakit? Delayed ejaculation can develop in any stage and may have a variable course. It can be influenced by biological, psychological, and social factors. Pag sinabi natin biological, of course, nasa genetics na yan or may problema talaga siya sa physical structure ng kanyang private part. And psychological would be low self-esteem or nagkakaroon siya ng problema to express or natatakot siyang hindi masatisfy si partner. And social factors, na dyan nagpo-fall yung nagko-compare sila sa other men. I actually asked a certain person about this, and yung social factors talaga ng delay ejaculation is big enough for them kasi parang pride nila yon as a man. Not literally pride as a man, pero malaking impact sa kanila na magkaroon ng magandang sexual performance. Minsan nga pineflex pa nila yun. So another topic falling from sexual dysfunction would be the erectile disorder, which defined as a condition where a man has a difficulty getting or keeping an erection firm enough for sexual intercourse. It's normal for a man to have occasional erection trouble. However, if erectile dysfunction is an ongoing issue, it can cause stress, affect our self-confidence, and contribute to relationship problems. Erectile dysfunction can also be a sign of underlying health conditions that need treatment and a risk factor for heart disease. Nakakabigla man, but it's true. Erectile disorder means walang kakayahang magkaroon ng hard penis ang isang lalaki through the start and end of sexual intercourse. Ibig sabihin nito, nahihirapan siyang magkaroon ng erectile through the whole process. O minsan, konti-unti, mawala, gano'n makatagal. O minsan, nagkaka-create din to na dissatisfaction sa female partner, no? After neto, syempre, magkwentuhan after this experience of sexual intercourse. When a male have erectile disorder, which means nahihirapan nga siyang patigasin ang kanyang private part. So, for diagnostic criteria nito, as I mentioned earlier, difficulty getting an erection during sexual activity. Difficulty also keeping an erection until completion of sexual activity. And decrease of erectile rigidity. Erectile rigidity means yung normal hardness ng penis sa isang lalaki. For its diagnostic features naman, erectile dysfunction needs to be persistent and recurrent inability to attain. Ibig sabihin nito, normal lang na from time to time ang isang private part ng lalaki is mawala ng erection. But erectile dysfunction means ang persistent niya na hindi kayang patigasin. Although, ang liit lang ng tagal bago bumalik ulit ito sa normal nitong hardness. But when it comes to sexual intercourse, hirapan siyang patigasin ng matagal. So, another features would be distress or impairment. The erectile dysfunction causes significant distress or interpersonal difficulty or impairs in individuals' function in other areas of life. Baka may problema siya, kaya nagkakaroon siya ng problema sa erectile disorder. And nahirapan siyang i-open up to sa partner niya, nahihiya. Another would be exclusion of other factors then, which comes, baka nagtitake siya ng other medicine, or meron din siyang other medical conditions or relationship problems. Baka si male naman ang hindi satisfied sa kanyang female partner. Also, napipicture din dito yung duration and severity. Usually, naglala siya ng at least 6 months and present on most or all occasion of sexual activity. So, minsan hindi natin matansya kung ito ba ay erectile disorder or just normal na pagbaba or pagtaas ng arousal ng isang lalaki. For erectile disorder would be the severity of disorder na either sobrang ikli ng duration ng hardness ng penis or utay or hirapan siyang i-maintain. In severity of the disorder, it can be also rated in mild, moderate, or severe, depending on the degree of difficulty and the frequency of the problem. So, development and course, paano nga ba ito nakukuha ng isang male partner, ng isang lalaki? Nagbabari siya. As men get older, erection might take longer to develop and might not be as firm. Men might need more direct touch to their penis or get and keep an erection. Various risk factors may contribute to erectile dysfunction, including medical conditions, particularly diabetes or heart conditions. So, nakukuha naman ang erectile disorder or nagde-develop siya through the hindi siya literal na genetics lang. It can fall to psychological problems and other factors kung bakit nagkakaroon ng erectile disorder.
Next is the female orgasmic disorder. This is where a woman is having difficulties in experiencing orgasm or its intensity has reduced. And the diagnostic criteria for this is that females that has experienced the symptoms where she's unable or having difficulties in orgasm has persisted on all or almost all of her intercourse and has experienced it in a minimum span of 6 months. If the said symptom is giving an individual or the woman rather a difficulty or that causes clinically distress over her, that could be considered as a diagnosis for female orgasmic disorder. Also, when it comes to diagnosing female orgasmic disorder, the woman should not be having non-sexual mental disorder or is not related in that, or also causing by a severe relationship distress, meaning if there is a violence, there's abuse going on in the relationship of the woman. Also, significant stressors such as substance use or like medication abuse or any other medical condition. There are also specifications when it comes to diagnosing an individual, the female orgasmic disorder. It is either lifelong, acquired, generalized, and situational. When it comes to lifelong, the disturbance has been always present ever since the individual, the woman, had started sexual activities or intercourse. And if it is acquired, the disturbance began after a period of relatively normal sexual function, meaning it has been acquired or been developed over a period of time. Next is the generalized. This is where it's not limited to certain types of stimulations, situations, and partners. And the situational, this only occurs with certain types of stimulation, situations, or partners. Also, the patient, the woman, should specify if she had never experienced an orgasm in any type of situation, such as masturbation, intercourse, like that. Also, the specifications of mild, moderate, and severe is also present. So, for a woman to be diagnosed female orgasmic disorder, they should have a clinically significant distress that accompanies the symptoms that has been experienced. So when it comes to diagnosing female orgasmic disorder, there are multiple things that should be considered because in many cases of orgasm problems, the causes are multifactorial or cannot be determined. Meaning, if a female orgasmic disorder is explained or is caused by another mental disorder or the effects of substance or medication abuse or just generally the effect of substance or medication. And next, if it's caused by a medical condition, then a diagnosis of female orgasmic disorder would not be made. Also, interpersonal relationships or interpersonal causes are also considered in this one, such as severe relationship distress, what is stated earlier, such as being abused or having problems inside a relationship, like violence or any stressors that are present, and that would also be considered for a diagnosis to not be made. In cases of orgasms, many women requires clitoral stimulation to reach an orgasm, and only few women has reported that they experience orgasm during a penile vaginal intercourse. When a woman is experiencing orgasm during clitoral stimulation, a diagnosis would also not be made as it does not meet the criteria for clinical diagnosis of female orgasmic disorder. Also, it is also important to consider whether orgasmic difficulties are results of inadequate sexual stimulation. In these cases, they may still need to work on it, but a diagnosis for a female orgasmic disorder would not be made. Proceeding to the last part of the female orgasmic disorder, which is the development and course. This is where if a female is having orgasmic difficulties, is said to be present, or as what is stated earlier, the acquired subtype would be a sign if the woman's orgasmic difficulties have developed over a period of time of normal orgasmic functioning. Also, female orgasm are developed in the pubertal period to well into adulthood, and also women experiencing orgasm is increasing also with age. So the more we grow, the more women age, their orgasm develops. Also, many women learn to experience orgasm as they experience a wide variety of stimulation, such as intercourse with the penile and vagina, and also with the clitoral stimulation. And with that, they also learn more about their bodies. So women rate their orgasms consistency with usually or always, and it has been reported that women experience orgasm mostly when they're having masturbation than sexual activity or intercourse with their partner.
Let's talk about female sexual arousal disorder. So what is female sexual arousal disorder? It means that this is a clinical term used to describe a persistent or recurrent inability to attain or maintain until completion of the sexual activity. It is an adequate level of sexual arousal or excitement necessary for the individual to achieve sexual satisfaction. This disorder can be primary, which means it has always been present, or secondary, meaning it developed after a period of normal sexual function. The diagnostic criteria for female sexual arousal disorder is outlined by the DSM-5. First is persistent or recurrent difficulties as manifested by at least 4 of the following in responding to sexual or erotic stimuli. A. Decreased or absent feelings of sexual excitement or arousal. B. Decreased or absent sexual or erotic thoughts or fantasies. C. Decreased or absent responsiveness to partner's cues. D. Decreased or absent initiation of sexual activity. E. Decreased or absent interest in sexual activity. F. Difficulty achieving or maintaining an orgasm or climax. And G. Marked distress or interpersonal difficulty related to the symptoms. The second diagnostic criteria for female arousal sexual disorder is the symptoms cause clinically significant distress in the individual or impairment in social, occupational, or other areas of functioning. Third is the symptoms are not due to the effects of a substance, medication, or another medical condition and are not better explained by another mental disorders such as hypoactive sexual desire disorder or relationship distress that is not related to sexual dysfunction. Fourth is the symptoms have been present for a minimum duration of 6 months and have not been present in all patterns throughout all or almost all of the person's relationship. Fifth is the individual is postmenopausal and is experiencing symptoms of menopause that may contribute to the sexual dysfunction such as vaginal dryness, then a diagnosis of female sexual interest arousal disorder rather than female sexual arousal disorder is appropriate. The causes of female sexual arousal disorder are complex and multifactorial, and it may include physical, psychological, and relational factors. Some possible causes includes first, hormonal imbalances such as low levels of estrogen or testosterone. Second, medical conditions such as diabetes, thyroid disorders, or neurological diseases. Third, medications such as antidepressants or blood pressure medications. Fourth, psychological factors such as anxiety, depression, or trauma history. And fifth, relationship factors such as communication difficulties, lack of intimacy, or partner dissatisfaction. The severity of female sexual arousal disorder is not explicitly defined in the diagnostic criteria outlined in the DSM-5. However, the symptoms are described as persistent or recurrent difficulties, and at least 4 of the symptoms must be present for a diagnosis to be made. The severity of these symptoms can vary from mild to severe depending on the individual's experience. Mild symptoms may include occasional difficulties with arousal or orgasm, while severe symptoms may include complete absence of sexual desire or arousal. The distress caused by these symptoms and their impact on social, occupational, or other areas of functioning can also vary in severity. A mental health professional can help to assess the severity of the disorder and develop an appropriate treatment plan based on the individual's specific symptoms and needs. Female sexual arousal disorder can be either lifelong, which is called primary, or acquired, called secondary. Primary disorder refers to a woman who has never experienced normal sexual function. It means that yung lifelong or primary, simula nung unang experience pa lang niya, hindi na normal yung sexual function. And then, secondary disorder refers to a woman who previously experienced normal sexual function but now experiences persistent or recurrent difficulties in responding to sexual or erotic stimuli. The duration of symptoms required for diagnosis is 6 months, and the disorder must not have been present in all patterns throughout all or almost all of the person's relationships. Therefore, it is not necessarily a lifelong disorder, and some women may experience resolution of the disorder with appropriate treatment. According to the Diagnostic and Statistical Manual of Mental Disorders, or DSM-5, the prevalence of female sexual arousal disorder in women is estimated to be between 10% and 15%. This means that approximately 10 to 15% out of every 100 women may experience female sexual arousal disorder at some point in their lives. However, the actual prevalence may be higher as many women may not seek medical help or report their symptoms due to shame, embarrassment, or lack of awareness. Female sexual arousal disorder can have a significant impact on a woman's sexual and emotional well-being, and it is essential to seek professional help if you are experiencing symptoms. Next is the development and course of female sexual arousal disorder. It means that it can vary from women to women. Some women may experience female sexual arousal disorder at any point in their lives, while others may develop it after a significant life event such as childbirth, menopause, or a medical condition. In some cases, female sexual arousal disorder may be related to psychological factors such as anxiety, depression, or relationship issues. Women who have experienced trauma or abuse may also be at higher risk of developing female sexual arousal disorder. The course of female sexual arousal disorder can also vary. For some women may experience occasional episodes of female sexual arousal disorder, while others may have persistent symptoms that significantly impact their sexual function and relationships. In some cases, female sexual arousal disorder may improve with time or with the help of therapy or medication. In other cases, it may require ongoing treatment to manage symptoms. It is essential to seek professional help if you are experiencing symptoms of female sexual arousal disorder. A healthcare provider can help diagnose the condition and develop a treatment plan tailored to your specific needs. Treatment may include therapy, medication, lifestyle changes, or a combination of these approaches. The goal is to help you manage your symptoms and improve your sexual function and relationships. The risk factors for developing female sexual arousal disorder include psychological factors such as anxiety, depression, and relationship issues, as well as physical factors such as medical conditions like diabetes, cardiovascular disease, and neurological disorders. Women who have experienced trauma or abuse are also at higher risk of developing female sexual arousal disorder. The prognosis for female sexual arousal disorder can vary widely depending on the underlying cause and the severity of symptoms. In some cases, female sexual arousal disorder may improve with time or with the help of therapy or medication. However, in other cases, it may require ongoing treatment to manage your symptoms. The success of treatment will depend on several factors including the woman's age, overall health, and the specific treatment approach used. It is essential to seek professional help for female sexual arousal disorder to develop a personalized treatment plan that addresses the underlying causes and the symptoms of the disorder. Female sexual interest arousal disorder can have significant functional consequences for women's sexual health and relationships. Some of the most common functional consequences of female sexual interest arousal disorder includes first, reduced sexual desire, which means women with female sexual interest arousal disorder may experience a significant reduction in their sexual desire making it challenging to initiate or maintain sexual activity. Second, difficulty achieving arousal. Female sexual interest arousal disorder can make it difficult for women to become aroused during sexual activity, leading to decreased pleasure and satisfaction. Third, decreased vaginal lubrication. Women with female sexual interest arousal disorder may experience decreased vaginal lubrication, making sexual activity uncomfortable or painful. Fourth, difficulty achieving orgasm. Female sexual interest can make it challenging for women to achieve orgasm, leading to feelings of frustration and dissatisfaction. Fifth, avoidance of sexual activity. Some women with female sexual interest arousal disorder may avoid sexual activity altogether, leading to relationship problems and decreased intimacy. 6. Negative impact on self-esteem. With this disorder, it can lead to feelings of low esteem and body image issues, further contributing to sexual dysfunction and relationship problems. The comorbidity refers to the presence of one or more additional medical conditions or disorders in addition to the primary condition being treated. In the context of female sexual dysfunction, comorbidity is common, and many women with female sexual dysfunction also have other medical or psychological conditions. Some of the most common comorbidities associated with female sexual dysfunction include: first, anxiety disorders. Women with female sexual dysfunction are more likely to have anxiety disorders such as generalized anxiety disorder, panic disorder, or social anxiety disorder. Second, depression. Women with female sexual dysfunction are also more likely to have depression, which can further exacerbate sexual dysfunction. Third, relationship issues. Women with female sexual dysfunction may experience relationship problems, such as communication difficulties, low relationship satisfaction, or partner dissatisfaction. Fourth is medical conditions. Women with female sexual dysfunction are more likely to have medical conditions such as diabetes, cardiovascular disease, or neurological disorders, which can contribute to sexual dysfunction. Fifth, substance use disorders. Women with female sexual disorder may be more likely to use substances such as alcohol or tobacco, which can further exacerbate sexual dysfunction and contribute to relationship problems. For the treatment of the disorder, treatment for female sexual arousal disorder may involve a combination of approaches, including psychotherapy to address psychological and relational factors contributing to the disorder. Second is medication to address underlying medical conditions or hormonal imbalances. Third, lifestyle changes such as regular exercise and healthy dietary habits. Fourth is sexual education and communication skills training for both partners. Fifth is couples therapy to address relationship issues contributing to the disorder. For our next topic, genitopelvic pain penetration disorder. It is a sexual disorder that affects women and is characterized by involuntary spasm of the vaginal muscles, making penetration painful or impossible. Let's first discuss the 5 diagnostic criteria for genitopelvic penetration disorder. So first, it is the recurrent or persistent genitopelvic pain or vaginal penetration disorder as manifested by at least one of the following. Letter A, superficial penetration disorder. It is marked discomfort or pain associated with vaginal penetration during attempted or actual sexual activity. Letter B, deep penetration disorder, which means marked discomfort or pain associated with deep vaginal penetration during intercourse. And letter C, musculoskeletal tension type, which means marked tension or spasm of the pelvic floor muscles, which it surrounds the vagina and anus, that interferes with sexual function. Second diagnostic criteria is the disturbance causes marked distress or interpersonal difficulty. Third, the disturbance is not due to lack of sexual knowledge, cultural or religious beliefs, or lack of desire. Fourth, the disturbance is not better explained by a concurrent medical condition, such as lichen sclerosus, lichen planus, or vaginal atrophy secondary to menopause or medication use. And the fifth one is the disturbance does not occur exclusively during the course of other sexual dysfunctions, such as sexual aversion disorder or dyspareunia due to physical factors. For the cause of this disorder, the exact cause of genitopelvic pain penetration disorder is not fully understood, but it is believed to be a result of a combination of physical and psychological factors. Some possible causes includes trauma or abuse. So for trauma or abuse, women who have experienced sexual trauma or abuse may develop genitopelvic pain penetration disorder as a result of the psychological impact of the experience. Second is anxiety. Anxiety, like women who experience high levels of anxiety or stress may develop genitopelvic pain penetration disorder due to the physiological response of the body to stress, which can cause muscle tension and pain. For the third cause of this disorder, it is the cultural or religious beliefs. Women who have been taught that sex is painful or shameful may develop genitopelvic pain penetration disorder due to the psychological impact of these beliefs. For the development and course of genitopelvic pain penetration disorder is still unclear. There are risks that we can discuss about genitopelvic pain penetration disorder. So first is the psychological risk. Women with this disorder may be at increased risk for anxiety, depression, and low self-esteem due to the impact of the disorder on the sexual function and relationships. Second is relationship risks. Genitopelvic pain penetration disorder can put a significant strain on intimate relationships, as women may avoid sexual activity altogether or experience significant pain during penetration. This can lead to feelings of isolation, frustration, and resentment in both partners. Third, physical risks. Physical risks. Women with genitopelvic pain penetration disorder may be at increased risk for urinary tract infections, vaginal yeast infections, and other genital infections due to the impact of the disorder on hygiene and sexual practices. For our prognosis, we will discuss 3 prognoses of this disorder. Let's start first with treatment outcomes. Treatment outcomes. The prognosis for women with this disorder is generally positive with appropriate treatment, which may include therapy, medication, and lifestyle changes. However, the success of treatment will depend on a number of factors, including the severity of the disorder, the underlying causes, and the woman's willingness to engage in treatment. Long-term outcomes. It means women who successfully complete treatment for genitopelvic pain penetration disorder may experience significant improvements in their sexual function and relationships. However, it's important to note that some women may continue to experience symptoms or recurrence of symptoms over time. Ongoing monitoring and follow-up care may be necessary to manage these issues. Third is prevention. There is no surefire way to prevent genitopelvic pain penetration disorder, as the disorder is complex and multifactorial. However, there are some strategies that we will talk about later that may help reduce the risk of of developing this disorder. So we have 3 strategies that may help reduce the risk of developing the disorder. First is open communication. Encouraging open communication between partners about sexual preferences, expectations, and concerns can help prevent misunderstandings and miscommunication that may contribute to genitopelvic pain penetration disorder. Second is education. Providing education about sexual anatomy, function, and health can help women develop a better understanding of their bodies and reduce anxiety about sexual activity. Third is self-care. Encouraging self-care practices such as regular exercise, healthy eating habits, and stress reduction techniques can help women manage underlying psychological issues that may contribute to genitopelvic pain penetration disorder. We have gender-related diagnostic issues. So by definition, the diagnosis of genitopelvic pain penetration disorder is only given to women. There are differential diagnoses, which is first another medical condition. Women with genitopelvic pain penetration disorder will also be diagnosed with another medical condition. Second is somatic symptoms and related disorders. Some women with genitopelvic pain penetration disorder may also be diagnosed with somatic symptom disorder. And then yung similarity nila is yung symptoms, which is pain and avoidance. But then yung somatic symptoms is less related siya sa sexual activity. Third is the inadequate sexual stimuli. It is the lack of sexual arousal or pleasure due to insufficient stimulation during sexual activity. This disorder is most common to the women who have the genitopelvic pain penetration disorder. Let's now talk about the comorbidity of this topic. First is anxiety disorders. Women with genitopelvic pain penetration disorder are at increased risk for anxiety disorders, including generalized anxiety disorder, panic disorder, and social anxiety disorder. This may be due to the impact of genitopelvic pain penetration disorder on self-esteem, body image, and relationships. Second is depression. Women with this disorder are also at increased risk for depression, which may be due to the impact of genitopelvic pain penetration disorder on mood and self-esteem. Third is the post-traumatic stress disorder. Women with a history of sexual trauma or abuse are at increased risk for both genitopelvic pain penetration disorder and PTSD. This may be due to the impact of trauma on sexual functions and relationships. Fourth is the substance use. Substance use disorders. Women with genitopelvic pain penetration disorder may be at increased risk for substance use disorders, including alcohol and drug use, as a way of coping with pain or anxiety related to sexual activity. Next and last one is the chronic pain disorders. Women with chronic pain disorders such as fibromyalgia or chronic pelvic pain syndrome may be at increased risk for GPPD due to the overlap in symptoms and underlying mechanisms.
Now, male hypoactive sexual desire disorder is characterized by a low desire for sex and absent sexual thoughts or fantasies. Moreover, male hypoactive sexual desire disorder is sometimes associated with erectile or ejaculatory problems. For example, persistent difficulties obtaining an erection may lead a man to lose interest in sexual activity. When men with hyperactive sexual desire disorder often report that they are no longer initiate sexual activity and they are minimally receptive, so partners attempt to initiate. These symptoms must have persisted for a minimum duration of approximately 6 months. The disorder causes clinically significant distress or impairment on age and general and social cultural context of the individual's life in the other areas of sexual functioning on the less than 2% of men age ranging 16 to 44 years old experience a persistent lack of interest in sex. Lasting more than 6 months, a desire discrepancy in which a man has slower desire for sexual activity than his partner is not sufficient diagnosis. For male hypoactive sexual desire disorder, it must be both low or absent of desire for sex, and deficient or absent of sexual thoughts or fantasy are required for a diagnosis of the disorder. Let's talk about premature ejaculation. Premature ejaculation or early discharge of semen is a very common problem in men. But surprisingly, only few people have the actual problem. Many men even feel they have an early ejaculation problem during masturbation, which is scientifically incorrect. So let's see what actually premature ejaculation means and how to treat this. The normal ejaculation time depends on the several factors. It takes an average of 5 to 7 minutes for a man to reach orgasm and ejaculate. But the overall range wide from less than 1 minute to over half an hour. International guidelines define premature ejaculation as regularly ejaculating within 1 minute of entering your partner. So it is diagnosed as premature ejaculation if the ejaculation almost always occur unintentionally within 1 minute of penetration. And this has been occurring for more than 6 months. However, it is up to you and your partner to decide if you are happy within the time it takes you to ejaculate. If ejaculation time are causing you persistent distress, then it's a problem and you should seek medical attention. Now, a few more things you should keep in mind. In medical term, it is not considered as premature ejaculation problem if it only happens occasionally. If you hadn't had sex for quite a long time, then it's normal to become aroused quickly and as a orgasm faster. And also, it is not related to masturbation. There are mainly two types of premature ejaculation. One, primary premature ejaculation, where you have always have the problem. And secondary premature ejaculation, where you recently developed the problem. The causes of primary premature ejaculation are often psychological, such as having a traumatic sexual experience at an early age. Secondary premature ejaculation can be caused by both psychological and physical factors. Physical causes can include drinking too much of alcohol and inflammation of the prostate gland. Now, before visiting a doctor, you can try a few self-help techniques. Masturbate 1 to 2 hours before having sex. It will decrease the sensitivity and excitement, which will help you to hold for a longer time. Try to use a thick condom. It will help you decrease the sensation, taking breaks during sex, and distracting yourself by thinking about something completely different can also be helpful.
And lastly is the substance medication-induced sexual dysfunction. This one occurs when there is a problem that leads to frustration during intercourse. And the diagnostic criteria for this one is that clinically significant disturbance in sexual function is predominant in the clinical picture, and also there is an evidence from the history, physical examination, or the laboratory findings of the following. So first is the symptoms that has been stated is that has been developed during or soon after patient has taken the medication, and also after exposure to a certain medication. The second is this involves substance or medication that is capable of producing the symptoms that has been stated earlier. Also, the symptoms that have been stated earlier, if the substance or medication used, if the symptoms persisted after they take the medication, and also having withdrawal to from a severe intoxication of a substance use or medication use. Also, so there is also some evidences that suggest of an existing independent non-substance or medication-induced sexual dysfunction, such as if a person have a history of non-substance or medication-related episodes of the sexual dysfunction caused by substance use. And the next criteria for this one is that the disturbance or the sexual dysfunction that is caused by the substance or medication-induced sexual dysfunction does not occur exclusively during the course of a delirium. Also, to be diagnosed with a substance medication induced sexual dysfunction, one must have clinically significant distress in the individual. So when it comes to the diagnostic features, the major disturbance that in sexual function of an individual is having a relationship with substance and medication initiation or dose increase of the substance or the medication, or also the substance medication discontinuation, meaning if a person stopped suddenly, even though it's not suddenly, if a person stopped a medication, a person would have a withdrawal symptoms. That could also be a cause, not just by taking, but also with the withdrawal of the medication. The development and course of the substance medication sexual dysfunction, there are medications that induce sexual dysfunction, such as antidepressant induced sexual dysfunction. This could be as early as 8 days after the medication is taken. And also, approximately 30% of individuals with mild to moderate orgasm delay will also experience spontaneous remission of the dysfunction in the span of 6 months. And also, the serotonin reuptake inhibitor is also inducing sexual dysfunction after the medication has been taken. So this is the withdrawal symptom type of medication that persists the symptoms or the substance medication induced sexual dysfunction. Also, the sexual dysfunction also occurs after taking antipsychotic drugs or drugs abuse of it is partly unknown, and it is also. And lastly, nicotine and alcohol. These are the substance that has been circulating everywhere and being used by almost everyone. This alcohol and nicotine could also have an effect in the substance medication induced sexual dysfunction, but this does not make it appear the symptoms as early, but would develop over time of use of the substance. There are also evidences that says that sexual functions disturbances is also related to substance and medication use of an individual. So using substance and medication that does not just come with how long we use it, but also as we grow, as we age. So that was the last disorder for this specific category of the disorders. But we still have two specifications, which is the other specified sexual dysfunction and the unspecified sexual dysfunction. First is the other specified sexual dysfunction. This dysfunction is causing an individual clinically distressed and the individual predominate, but it does not fully meet the criteria for any diagnosis of disorders in the sexual dysfunctions disorder. And also, the category used in the situations of which the clinician chooses to communicate the specific reason that the presentation does not meet the criteria for any specific sexual dysfunction. That is also followed by a specific reason such as sexual aversion. The last is the unspecified sexual dysfunction. This is where a symptom persists and it characterizes the sexual dysfunction that caused clinically significant distress in the individual, predominate but do not meet the full criteria for any of the disorders in the sexual dysfunctions diagnostic class. Also, this is also used in situations